So hi there, my name is Eric Weil. I'm Associate Chief for Clinical Affairs over at Mass General. I'm a primary care physician over there, or general internist, or whatever you choose to call me today. Pardon me?
Cool guy.
Cool guy, you can call me cool guy. I just wanted to first of all thank you all for the opportunity to be up here. I have been in a terrible mood for probably the last 3 or 4 weeks. I feel like this is like an AA meeting. Hi, my name is Eric Weil. I'm a primary care doctor. It's been, I started drinking. It's every now and then you get really worn down. Sometimes it's really hard to work in the office, and sometimes when you're in a position of leadership, you interface with other people who are having a lot of trouble working in the office, and you begin to forget after a while the mission, the things that actually make you get up, come to work in the morning. And a session like this today is really, really valuable because it kind of like splashes a little bit of water on your face and says, this is why we do what we do. And there are ways to really take joy and pleasure in our work, and there are really wonderful opportunities for us to do something really important and really special. And so listening to people talk about the pathway that they want to take and how they think they could change the way we deliver care is really, really cool. So I'm absolutely honored to have been allowed to sit here and listen to that. And now the really exciting part. We're going to have, for the next 45 minutes or so, a conversation with people with all sorts of different insights into primary care and healthcare delivery. I'll introduce them individually as we go along, but really the concept here is that we're going to talk a little bit about what's working and what's not working. What are the ways that we can equip and empower, improve what we're doing, move forward to the next step. Now, I guess you could say that there are a bunch of different scenarios for the way that healthcare could look in 10 years. It could be really bad, or it could be really good. It could be the type of system that we all envision. And so as you guys kind of talk to us about the big idea, the question is, 10 years from now, what are the things that we need to be thinking about in order to get to that point? And so on that note, I'm going to briefly introduce panelist number 1, and this is Dr. Arsha Vahabzadeh.
Right.
Good, nailed it. He's a psychiatry resident, a PD psych resident, but has also been a general practitioner in the UK. And so he's going to offer us some very interesting insight from 2 different points of view right now. And so my understanding is that for the big idea, we get about 4 minutes. And so I'm going to turn it to you for the first 4 minutes.
Fantastic, thank you very much. So one of the things I wanted to talk to you about was when I was in England, being a general practitioner, I did my residency there, and I used to see some patients with some really challenging mental health conditions, and they used to see a psychiatrist. So when they used to give me a lot of information about their mental health problem, I would often say to them, well, when's your next appointment with your psychiatrist? They'd say, it's next week or it's next month. I'd be like, you know what, that's a great opportunity for you to be able to talk about these issues with them. I spent a bit of time in Atlanta, and when I was in Atlanta, I was training in psychiatry. And what I found then was that I used to have patients coming to me with a lot of medical problems. And I did the same thing. I used to say to them, well, you've got all these medical problems. When's the next time you're going to see your doctor? They're like, you are my doctor. I'm like, no, you're your primary care doctor. They're like, but you're my only doctor. I'm like, oh gosh. And you start to realize that access to care is really difficult. Some patients simply don't get it. We often live in our healthcare system in silos where mental health and primary care are operating independently, even though our patients, their conditions, many of our chronic illnesses are running concurrently, whether they're deemed to be mental health, whether it's depression, whether it's anxiety, whether it's ADHD, alongside diabetes, hypertension, congestive heart failure. And the fact is that whenever we don't treat one, the outcomes are worse for the other. So one thing that's very important is that we have to treat both, and we have to give our patients an opportunity to get their care at the same location, and ideally in this integrated setting. And what I mean by that is having people that are accessible to them, that they don't feel that they're stigmatized or having barriers in terms of talking to one individual over another. And we also have to look at a population approach to behavioral conditions. We simply don't seem to have the time to be able to spend an hour with each patient. That kind of old and more historic ways of psychiatry and mental health care was being practiced, when we need to really look at our patients, just as a lot of medical specialties are doing, as a population-based approach. And we need to do that in a very integrated way. One thing we saw a lot of our submissions talk about is behavior. When behavior reaches a threshold, we label it as a mental health problem. But all the way down a spectrum, we have people undertaking behaviors that may not be helpful to them. Person smokes or binge drinks a couple of times on weekends in a month. That may not be helpful to them if on those days they don't take their blood pressure medicines. So we really have to think about behavior also very much on the spectrum. Is that my 4 minutes?
That is in fact, that is not. That is in fact your 4 minutes. Thank you very much. Now it's working. There we go. Thanks. Hey, your mental health is in my primary care. Hey, your primary care is in my mental health. Tastes great. Our second speaker this evening, I'm sorry, is Dr. Andrew Morse Singer. Andrew is president and principal founder of Primary Care Progress, and he's a clinician, educator, and advocate who works in the space of primary care vitalization. He's currently living on the West Coast, where he's still an actively practicing physician, I believe. We miss him out here, but we're glad to have him back, even if it's just for a little while. And we'll now turn the floor over to you.
Thanks, Eric. So quick disclaimer, I realize I look like a pre-med, but I promise you that I finished residency. I am so impressed by this event. And I am so energized by this event. And it's not the ideas that folks were just presenting, actually. It basically is sitting in a room with people who are broadcasting their values and their passion and their confidence that they can actually help save primary care. And that's how we're going to reinvent and save primary care in this country. It's literally going to be us coming together and believing in ourselves and advancing innovation. But here's the thing. Here's what I want to talk about. If we don't advocate for the resources that we need to sustain your innovation, I don't think we can keep it sustained. So that's what I want to talk to you about. I want to talk to you about advocacy and how it fits in with what we're trying to do here. So who am I? So I actually used to work as a community organizer, professional community organizer, just like the president. I don't know if that's a good thing anymore. It was in the LGBT community. So I came out in college and I got involved. And this was over like 15 years ago. So this was way back before same-sex marriage, right? This was way back before that. But here we are, 15 years later. We've got over 15 states in this country with same-sex marriage. Why? Because of community organizing, social strategy, and money, the package. And the reason I bring this up is that I think we can assemble a similar package in primary care right now. Okay, so definition, what is community organizing? It's people coming together to fix a problem that they could never fix on their own. And I know what you're probably visualizing is community organizing. Okay, so that's like the civil rights movement, the LGBT rights movement, right? It's large groups of people around a big problem. But community organizing is also, the students and residents at a medical school that isn't taking primary care seriously advocating. Right? It's the members of a clinic who need the hospital system to give them the resources they need, advocating to go get those. Right? Now, here's the question though. What is the ideal situation for community organizing? It's where there's a problem that affects a large group of people, and they feel deeply, deeply passionate about it. And it's not just a small group of people, it's really a large group of people. That's what we have in primary care right now. I mean, think about it. We've always had the primary care people feeling like they needed more, feeling like they've been misvalued, essentially, left out of academic institutions and healthcare systems. But now, in addition to that group, we have a multi-stakeholder coalition that's coming together to support primary care. That's effectively what Marcy runs. That's Marcy's job. She runs an organization that has put together this amazing coalition of people who feel passionately. Payers, purchasers, providers, community advocates. And they're putting money on the table. So that's the situation that we have right now in primary care. So the question is, how do we leverage it? How do we leverage that money that's on the table? How do we leverage this moment of crisis and opportunity? And that's social strategy. So social strategy is, what is your approach to the person or institution who can give you what you want? What do they care about? What are their motivations? What are their interests? Think about a professional problem that you're facing right now. Who can give you what you want? Who can fix your problem? What do they care about? And what resources do you have to leverage that interest? That's the biggest question. Very few of us ask it. If you look at health professionals and say, what do they believe their resources are and power is to get someone to give them what they want, it's clear what we think. Data. We think that data is the only form of power that we have. Data is necessary, but not sufficient. So what other resources do we have? Well, a group of students and residents at this medical school realized that they had their voices, they had their relationships when they advocated 3 years ago to get a new center for primary care here. It wasn't the data that was pushed forward. It was the data in concert with the community mobilization. Right? And what did a Northeast practice director, medical director at a Northeast practice do in order to get funding from the hospital to actually subsidize all the amazing things, all the amazing innovations he wanted to do? He leveraged the interests of that academic institution, which was now an ACO, and now had to manage the health of a population, leveraging those interests, those resources. We do this in our clinical lives, right? That's what motivational interviewing is, right? It's acknowledgement of the person in front of us. What do they actually care about? They don't care about the data, right? You're gonna die of smoking. Here's the data. It's dangerous. Heart attack, stroke. They don't care. What do they care about? They care that they huff and puff when they go hiking. And once we start acknowledging that and leveraging that, they actually start changing their behavior. And we do this in our clinical lives. What about bringing it into our professional lives, our public advocacy lives? That's what we gotta do. I think that's what we gotta do to save primary care. Your innovations plus advocacy, and we are gonna rock and roll.
Thanks, Andy. Our next speaker has already spoken once. And so I don't believe I need to offer him a second introduction, but this is Dr. Asaf Baton, who's one of the core faculty leads for the transformation strategy and design for the Harvard Medical School for primary care. And I'll turn it over to you.
Well, thanks. I'm ready to follow you into the breach. So Andrew and I have got, I've had the privilege of working with him for 10 years. It's always hard to follow you, but I believe in not bearing the lead. So here's what I want you to take away from my 4 minutes. The bottom line is we are a lot closer than a lot of people think to having this be the primary care moment that we all want it to be. What do I mean by that? It means that primary care, no doubt, has been in a beaten down mode for 30 years. It's been a profession which has been hard to attract folks and retain folks into. But instead of focusing on that past, I really want to focus on not only the future, but also the present, which is there is this incredible moment, this incredible sort of 3 to 5 year period right now that we have in which the alignment that Andrew started to discuss around all the forces in our messed up healthcare system seem to inextricably and somewhat surprisingly, but oh so rationally converge on the concept of primary care. There is no sort of way out of this morass without primary care being one of the 2 or 3 leverage points. It doesn't work. You can dream up all the value-based purchasing. You can dream up all the wonderful reimbursement schemes. You can dream up all the things that you would like to on the left and this political spectrum and on the right, but they all eventually at some point go through primary care. It's not the only answer, but it is a necessary part of the answer. And Marcy can tell you this, and I can back her up, but because I get to spend a little bit of my time in the snake pit known as Washington, there's almost nothing that anybody in DC agrees with. They can't agree about whether the sky is blue on sunny days, but unbelievably, they still manage to find themselves on both sides of the political spectrum supportive of primary care, and it's not just in words only. It's in action. It's in this incredible shift that you're seeing right now in places like Medicare, not just through their innovation center, but in their fee schedule, in the ways that they're thinking and acting about all of the inefficiencies and misalignments that you've heard today. This isn't a matter of hoping and wishing that this will come in 5 years because we're primary care and we're beaten down and we're a charity case. We are not a charity case. We are sort of, you don't pass go without going through us. And so if you're a medical student or a person in an affiliated health profession that is considering either going into primary care or working more with primary care, the answer is yes, yes, and yes. And it's not because I'm hopelessly biased. It's because there is no other way but to expand and develop this field. It will be. And so if you're a person that's interested in the intersection between community and context and looking at the whole person and understanding connections between mind and body and policy and disparities and equity, or all of the above, this is your time to join in primary care. If you're a person who's been in primary care for 20, 30 plus years and you're wondering whether it's time for you to leave, it's actually time for you to double down on primary care. It really is. And the other thing about it that's incredible is that, yes, while some of the details of the answers to our conundra remain somewhat elusive, how do we implement things like team-based care through the medical home? What are the best strategies for payment? How do we work with payers who want to sort of channel themselves outside of the payment system, like what Ali's going to talk about? What are the best ways to integrate behavioral health? I agree the details need to be worked out. The larger canvas is actually pretty well sketched out. And the question for you to ask yourself is whether you're going to be a playwright or a critic. Are you going to write the next chapter here? Are you going to sit from the sidelines, say it can't happen, whine about it, say it's never been done, and the same thing is going to happen over and over again? It's not. And obviously, it's trite to say that history repeats itself, so let me repeat history. I'm going to read here a wonderful little snippet from a great article, which says the outpatient clinic does a number of things. It is when a patient leaves a hospital bed, he or she frequently requires further medical supervision. The outpatient clinic, if properly equipped, can provide with benefit to the patient and direct economy to the hospital that supervision. Many are the readmissions to the hospital wards caused by too early discharge at first admission. Thus, the dispensary, the primary clinic, bridges the gap between ability to walk and ability to work. This would be from the illustrious Boston Medical and Surgical Journal, now known as the New England Journal of Medicine, on August 27th, 1914. 100 years ago, almost to the day. Now, to the question to the naysayers of whether people don't know how to reorganize themselves into teams to better care for their patients in primary care, according to Michael Davis in the Boston Medical and Surgical Journal, August 27th, 1914, the best medical works requires cooperation in diagnosis and team play during treatment. This cooperation and team play is impossible or is uneconomical without organization. At the present time, medical work almost always involves or ought to involve more than one person. So 100 years ago, Michael had the start of an answer. 100 years later, we have more and more aligning around the answer. The question isn't whether to go in primary care or whether to stay in primary care, but it's how best to maximize your journey in primary care and work with these incredible innovators that you saw who are taking innovation from that kind of gadgetry, wizardry thing that's kind of snazzy technology and saying, really, what are the ways in which this builds systems of care that builds better lives for our patients?
Thanks. I can't help but think that if that article hadn't been lost, things would be different right now. Absolutely. So our next speaker is a non-physician. And that's a good thing. A day late and a dollar shy. I'm very glad you're here. I'd like to introduce Janice John, who is the Chief Primary Care Physician Assistant at Cambridge Health Alliance. Cambridge Health Alliance is an absolutely wonderful, spectacular organization that does work that probably deserves another 2 to 3 hours just to begin to scratch the surface of what they do. But Janice, I'm going to turn it over to you to talk a little bit about the team model and how you're using that within an ACO to kind of harness the type of role that you play and others play in a medical home environment.
Thank you. So I'm a PA. I have been a PA for about 13 and a half years, and I have been one of about 30% of PAs who have spent my entire career in primary care, and I feel so lucky to have been in primary care for this whole time. And for the past 2.5 years, I have been at Cambridge Health Alliance, but specifically at, I've done my clinical time at Union Square Family Med. Union Square was recognized by Robert Wood Johnson last year as one of the top 30 innovative practices doing primary care really well, which was so exciting. But the thing is, even at our clinic, it's hard to be a PCP. It's hard to be a primary care physician. It's tiring, it's exhausting. And so I think that from the front lines, the couple of things that I want to share are, one is culture is really important. It's something we need to spend a lot of time thinking about. How we relate to each other on the team, that really matters. It's one thing to delegate pieces of care. It's a different thing to share care of the patients. And I think that when we can share the care of the patients really well, it not only helps the patient, it helps each of us have a higher level of compassion. But it also helps us. It helps us not burn out as rapidly when we're able to share with somebody else who knows the patient really well that really tough interaction that we had. It's very different for me to talk to someone who's never met a patient and just kind of, give my vent, but to really share that care is a whole different thing. And I think my clinical time is at Union Square. My administrative time is trying to spread this model across 8 or 9 primary care practices. And what I'll say is the places that it's gone really well is because there's a culture of sharing that was already there to some extent, and a culture of teaching. So teaching and learning. Doctors are not the only teachers in a team-based care model, right? There are members of your team that will know a cohort of patients or certain things often much better than the physician. PAs are just one example. But it translates to nursing really well. The PAs that we have in our larger primary care group, 50% of our PAs are first-generation immigrants. We get what the challenges are for immigrants in our system. 50% of our PAs came out of a specialty, came out of ER or orthopedics or whatnot. They have a lot to teach, right? So I think that kind of conceiving of the team as not just a place where the physician leads, but really where we work together, where we're all learners, where we're all teachers, and trying to figure out how to best utilize the member, how to best work together, not utilize the members of your team, but how to best work together. I think that's actually one of the best things that we can do looking forward. Tom Bodenheimer did a great paper last year out of UCSF talking about team culture and actually studying whether or not team decreases primary care burnout or not. And so what he showed was that yes, it does, but only if there's a strong team culture. So anyway.
Thanks. We have one more speaker, and that's Dr. Ali Khan. Dr. Khan trained at Yale New Haven Hospital. He, in his description, he is humbled by the service, but I believe that he is actively involved in a great many organizations across the country, including the American College of Physicians, Physicians for Human Rights, Doctors for America, and the Virginia Commonwealth University. And I suspect many other things as well. So I'm going to turn the floor over to you as our last speaker, and then we'll open up the floor to questions.
I'll be quick since I can't really follow these guys as much. That being said, I think what we'll talk about briefly, so I'm here wearing two different hats. One, they don't necessarily make a lot of sense. One coming from my work with the American College of Physicians as their chair of their National Council of Resident Fellow Members, a legacy membership organization that really obviously has done a lot of work in thinking about healthcare advocacy, healthcare policy, but very much representing a lot of the old guard of American medicine. And then my day job, which is a total joy, working as a staff physician in Las Vegas and a clinical innovator at IR Health. Up the street where, to be brutally honest, we try to break as many things possible to restore humanity to healthcare. And so it doesn't really necessarily, for a lot of people, make sense as to why those two missions or those two organizations would make sense. Certainly my wife questions me all the time. But for us, I think what really matters in this context is that despite the different paths of those kinds of organizations, be it ACP's work in the High Value Care Initiative or the work we do at IORA, both are really focused around the same mission, which is a relentless pursuit of trying to do better in American medicine and of affecting a sea change. And I think for us, both from the AACP context, but also from IORA, we feel that the lurking variable, or what I think is really the secret weapon, is thinking about how we train our current and next generation of primary care providers to really be the people to break stuff. So in that context, whether it's thinking about how we educate providers across the country, be they physician or non-physician providers, and delivering high-value care, or whether we look at the context of the work that we do at IR Health in terms of arming people with the skills necessary to lead primary care change, we'd really feel that there's an intrinsic toolkit that's necessary for this to work, no matter at what level you are. And it's some of the words we've heard today. It's management. It's a deep, strong fund of knowledge and that's guided by evidence. It's strong grounding in advocacy, and it's a real centering around public service. So the programs that all these organizations do, the programs and the work that we all do, is really well focused on that singular goal. And it makes me think, so 6 years ago, actually, I sat in a classroom not too far from here and listened to two Harvard Business School professors, actually with both of these guys in the same class, really just offer one very simple truth and challenge to think about what we can do. And that was, surely, in American medicine, we can do better. And I think the work that we attempt to do in terms of thinking about how to train the next generation of primary care providers as that secret weapon is exactly that sense. So.
Thanks very much. So we have about 30 minutes left. The purpose of this last 30 minutes is really to pick the brains of some really smart, thoughtful individuals who have now kind of given you a little bit of a background on who they are. I have some questions I can ask, and I think that it would be disastrous if I was the person to ask all of those questions. And so I'm going to strongly encourage you all to participate in this conversation as much as you possibly can. I will start, however, with just a quick question about culture, because you brought that up. You know, there's a certain axiom that we have when we're talking about treating pain, which is that it's much better to stay ahead of pain than to have to treat it once it's already there. And I think culture is a very similar thing. You talked about having a good culture, and in the places where you had a good culture, implementation and innovation really came in a very natural fashion. But I suspect that for some of those other 9 practices, it may not have been that there was a healthy culture in the first place. And so my question for you, and then more broadly, is what are the steps that you need to take at the start to begin to change culture?
So I think that the first thing is hiring with a mission in mind every time, right? So, but not just docs. Actually, most of the time, the docs get that part right. Docs are mission-driven folks, especially docs who end up in community medicine. But when you hire your frontline staff, making sure that at every step of the way, it's the entire team that is doing the interviewing. So I think I think that's one thing. I think that really engaged leadership that engages the front lines in innovation. So, you know, whether that's having improvement teams that are really multidisciplinary, that are moving things forward. I think that's a big piece. But then really making sure you have a carve out for team time. If you don't have that, then you'll never build those relationships. So. Yes, it's one more thing to take that time to share story, but it's not just if you think of it as a burden, then it will be. But if you think of it as time to share and realize that we're all learners in this process as well as teachers, then that makes a huge difference.
That's great. Any other comments on that one?
So on last Friday, I was actually sitting with an advisor from NIMH and the healthcare systems team at the American Psychiatric Association, and we talked about culture. And one of the things that came up is that changing the culture of psychiatrists who are already established in practice to allow them to integrate into primary care is actually much more difficult than intervening in the educational process and training psychiatry residents to think differently and think much more integratively with their kind of primary care peers. So what we find is a lot of resistance from established physicians, established psychiatrists saying, look, I want my 1 hour with a patient, I don't want to change my practice, compared to residents that we can kind of train to think, no, you know what, you can get curbsided, you can look at a roster of different patients with your primary care colleagues and work through some problems. So I think targeting early and getting the cultural change much earlier in training is really useful.
Well, and so that's a really good point. So Ali, the IORA practices, you do this like from scratch basically. You build the practices from the ground up with that culture, like, you know, baked into it. I mean, that's always been my impression. What's the strategy that you guys use when you're kind of putting together one of these break it all kind of practices?
So it's actually surprisingly simple.
Oh, okay.
All
right, good. Cool. Quick.
We hire for passion, and we can train people for skill. So obviously our model shifts primarily from thinking about a provider-patient dyad to really thinking about a provider, health coach, patient triad, as our colleagues at Twine know quite well. And thinking of that as the context of really being the mechanism of actualizing how our patients are going to transform their lives and really impact their overall care experience. So for us, what that means is that the most effective health coach may not be somebody, or the most effective provider may not be somebody coming from Harvard Medical School, or may not be somebody with a background in therapy or a background in, you know, health coaching or certification from Duke, but maybe the person who we found at Target who sold our CEO Rashika a shirt and had just amazing service excellence, right? Or it could be the union worker who has stood in picket lines and rallied people around for the past 7 to 10 years before coming to work for us and suddenly becoming incredibly enthusiastic about teaching her patients how to text their fasting sugars into our EMR. This is, I mean, that more than anything else, the mechanisms by which we maintain that through dedicated team time, through dedicated huddle as a patient, not as a team, not for 5 or 10 minutes, but for 60 to 95 minutes a day. Those are all the things that we do to sort of maintain that culture. But finding the people, involving the people that we already have in multiple stages of the process to bring them in and then to train them is really just that. It sounds deceptively simple, but it's the truth.
Well, finding those people sometimes is like finding a diamond in the rough. Can you make them? Can you bring the passion to people?
I think you can find people in a lot of unique areas who have the passion to do this kind of work who may not know it yet. But the question is that how do you reach them? And that's an open question for all of us. But I think for us, what we found is that telling the stories of our patients and trying to show how we impact their lives can be profoundly powerful for anyone. And the motive to come in Brooklyn, we have a former appellate judge who's now a health coach, and he's teaching Tai Chi on 2 days a week. So clearly it's a wide variety of people who we can find who are looking for something meaningful in their lives and wanting to do something to impact other people.
A former appellate judge coach teaching Tai Chi. How many of those do you have?
One so far.
Just one. Okay, I was just double checking. Questions from the crowd? Say your name first, or who you are and what you want to do.
Sure. My name is Andreas Mitchell. I'm a second-year medical student here at HMS. I want to go to primary care. I guess. Oh, sorry. That sounds about right. So I guess what I'm hearing is a lot of really exciting visions for primary care, and I'm also hearing a lot of barriers to achieving those visions. But I guess what struck me recently is that as ambitious as the vision already is, it feels like it might be coming up short, and it feels like we're at an opportunity to do something really incredible, and we have the chance to break things and try to build out the primary care of our dreams here. And it just feels like the primary care we're dreaming of, that I read articles about, is gonna fall short. And what I mean is that the ideal version of primary care, at least as well as I've heard it explained, is that the homeless patient's gonna come in, or maybe even not come in, and she's gonna get her blood pressure down and she's gonna get her hemoglobin A1C under control. But as far as I can tell, the ideal primary care we have isn't gonna help her find a home, it's not gonna help her find a job. It's not within our metrics to achieve that for her. And maybe there's a chance that with financial incentives, maybe it'll be financially viable for us to find her a job or a home in order to get her A1C down. But we don't see these social factors, these life goals, as ends in themselves, as far as I can tell. And so I'm wondering whether I'm misunderstanding or whether there is possibility within primary care to help people achieve these broader things that we really think are important when we see the patient as a person. So I saw if you were talking about the beauty of primary care to address the whole patient. And I guess in my experience, I just haven't seen that totally.
So if it's okay, I'd love to field this a little bit. I spent about 8 years in healthcare for the homeless before coming over to Cambridge Health Alliance. And I think there are actually lots of answers to this question, and I think it's actually in every one of our hearts. But I think the answer is that this is not the job of primary care medicine, but it is the job of primary care to be really, so again, if we work really well together within our teams, what if we work really well within the community? So I think that having strong community organizations and partnering with them well is really important. That said, Stout Street Clinic out in Denver, take a look at what they just did over the past week. They just built housing above their clinic, right? So yes, housing first, and finding how to do those models really well, but and being very involved as primary care teams in that type of advocacy. But as a primary care clinician, you're not going to get your patient housing probably.
Can I sort of just add a quick sort of tack on? I guess it's, I totally agree that it's not necessarily within the scope of primary care, but I guess when we talk about what primary care can be, will be, we talk about the team within the clinic, but we never talk about branching to those community organizations as part of what we do. And I also don't see within our ideal primary care, I don't see that clinic in Denver being reimbursed for that. I just haven't heard that.
I could do. All right, so I'm not one of the speakers, but I'm going to comment on this one a little bit. So I think it's important to differentiate a little bit between healthcare and health. And I think it's the responsibility of healthcare providers to help promote health and actually engage and start that conversation. And you can actually think about a medical home on a broader level, particularly through community health centers, as you can almost call it a community-based health home. And an effective community-based health home has arms that reach out into the community and actually advocate within that community. So in Revere, we help facilitate farmers markets to promote healthy food in the community, and we help drive coalitions that deal specifically with substance use disorder in teenagers. And so then it becomes a part of the broader health mission of healthcare to do exactly the things you're talking about. Now that's unfunded, at least it's unfunded in an ACO, and it's unfunded as part of what an insurer will pay you. But as a part of a larger healthcare system, it is beneficial to that system, whether it's Medicare or it's an ACO, to actually promote the health of a broader community. And so you'll see this in places like Cambridge Health Alliance, or you'll see this in a system like Partners or other systems, that part of their strategy actually is a health community-based strategy. And so look for it. You'll actually see more of it out there than you think. It tends to be a second or a third mission, but it's always one of the ones that supports the healthcare component.
So, Andres, I appreciate your question. So about 17 years ago, I went to hear a woman speak in Boston. I was going to school at Brown in Rhode Island. And her name is Rebecca Oney. And she was talking about this kind of idea, this kind of new thing that they'd been trying at Boston Medical Center that was at that time called Project Health. It's now called Health Leads. And many of you may know this organization, but it does exactly, it starts to create the tentacles exactly that you're talking about, and this model has been replicated. The model is take college students and other advocates, give them intensive training, and have them serve in clinics that have these high social needs, and have them be effector arms so that when the provider sees the patient who's homeless or who needs food, that provider literally writes a prescription, and that prescription is then made actionable by these advocates. There are now almost 1,500 advocates a year that are actively involved in 7 sites across the U.S. at Health Leads. They serve about 15,000 patients. The model is replicable. It shows good results, and it's just one form of that interconnection between public health, between the social sector and primary care. I don't disagree that we would all benefit from adopting not only the Health Leads model, but beyond. So what troubles the patient that Andrew and Erica and I at our South Huntington clinic at JP, what troubles them is her homelessness, the bipolar magnified by depression, but the bipolar magnified by food insecurity and violence in interpersonal, domestic violence. The question isn't whether she would be better served by us being able to completely integrate, but rather at what point in this continuum of what we offer are we going to act now? So 5 years ago, 7 years ago, the debate literally was, and Eric remembers this quite well, we don't really know if teams are really a good idea. You remember this. I'm not sure that it's a good idea to spend an hour a week talking in teams, because that's revenue lost, right? I mean, we were having these completely asinine discussions, and with very smart people, and I get where they were coming from. I can quantify that RVU lost, and that's, $112 of time that I want back, and you're saying you want to talk about quality? What's quality anyway? Okay, so fast forward 5 years later, we've won that argument. There's nothing really to discuss about the value of team time. There's a lot to discuss on how we do it, on what the best way to start, how do you intentionally build culture. In the same way, integrating social needs in the social sector approach, we're at that moment in time with primary care. There's a little bit of debate saying, it's not really our job. Our job is to see sick people and provide sick care. I think that's turning into a question of really, what are the ways in which we're going to do it? What are the ways in which we're going to do it in a way that can basically cover our butts right now financially so that we can do the right thing better and better year after year. This is what I'm talking about when and again, I'm an optimist and I believe in optimism as a strategic imperative. I really do. So I'm telling you that I see this sort of coming along, but it comes in stages. And if you reach too far, you get your hand slapped. And that's actually what's really interesting. You might want to push us a little bit here. Take a person like Ali and Iora and take clinics like ours. There's a real interesting dynamic right there of revolution, break a whole bunch of stuff, and evolution, work in big systems like we do to year by year, grade by grade, get better at scale. There's a different scale strategy here. There's a different scale strategy. I have no idea which is better. Maybe we should just, some days I wake up and we should just break the whole thing and call it a day. And some days when I see massive change affected, like in our work at Partners that Eric is leading with Susan Edgman, Levitan, and a bunch of other people, you see, wow, you make 5% change at a 270 clinic scale for 1 million patients. That's a big bleeping deal, right? Right. So I mean, that's all I have to say.
That's a big bleeping deal.
Yeah. So I just wanted to sort of build off something you said, Andres, where you said I'm concerned or afraid we're going to fall short, and we have to fall short. We have to look forward to falling short, because that's the only way we push ourselves as a community. Have you heard the concept of fail forward? Ali, I bet at Iora, and we haven't spoken about this, I bet you guys discovered some of the most innovative, awesome things that you're doing by trying stuff and failing and trying other stuff and succeeding, and you weren't exactly sure what would work when, but you realized you just had to try different things because this is a complex adaptive system.
It's reality.
Right? Failure happens every day. We as a medical culture, we fear failure, and we fear failure publicly. And we have to move in the opposite direction. We have to embrace the fact that we're gonna fail, because that's the only way we can learn. And here's the second thing. Share your failures publicly, right? Share them publicly, because you do two things then. Not only do you share a strategy that may or may not work from someone else so they might learn, but you're broadcasting to the community that you're surrounded by that this is what you're supposed to do. As a primary care leader going forward, you're supposed to fail. It's like, Asaf, you probably don't even remember this. When I was an intern and Asaf was a resident, one of the questions I asked was, Asaf, how do I know how many chest films to get on all these patients coming in with shortness of breath? And one of the things he said is, if every single chest film you get has a pneumonia on it, you're not getting enough chest films. And it's the same way. If all you're doing in primary care revitalization is succeeding, you're not trying enough stuff. You have to fail. That's the only way we're going to move forward.
Fail well. Other questions? Please.
So the Institute of Medicine just came out with this great GME suggestion to reform how we think about things. And I think it taps into a little bit of what we're talking about here, about appreciating population health and your community. And if you're not able to obtain the outcomes that appreciate that value, then funding should be shifted. What do you guys think about that in terms of its implications and how we practice primary care? And how do you see that affecting how we think about funding of medical schools? I know that the social medicine ranking kind of touched a little bit on that, but do you foresee this happening in the future to impact medical education funding?
Okay, you're gonna hear from me again. Yeah, so just to make sure we're all on the same page, so the IOM, Institute of Medicine, just released this report, this huge report on the governance and financing of graduate medical education. And it was an amazing shot across the bow of academic medical centers. It basically said there is profound misalignment between what you academic medical centers are doing and what society actually needs. Not only are you not training the number of health professionals, number of physicians in the specialties that we need, primary care, but it's not clear that the people that are being turned out have actually the skills that they need, skills that we talked about today. And they basically said, we believe you actually need to have an incentive. We're going to change funding. We recommend that Congress pay differently. Congress has been paying for graduate medical education in a very particular way since 1965, when Medicare was set up. It hasn't changed. It's not transparent, there's no accountability. It's a massive sum of money, about $15 billion, to academic medical centers, to hospitals, and there are no requirements that they actually produce what society needs, the public good that this money was seeking to promote. And I think a flip is actually going to be coming down the line. I think we're going to see more family medicine residencies. I think some of these hospitals are going to get squeezed, and I think they should get squeezed. This is public dollar. Right? They should be accountable. So I'm really excited about it. It's not going to switch immediately, but it's coming.
So I'll just add, the ACP has a long perspective on this, which I will not go into. That's quite nuanced from the policy perspective. But so tying GME funding and thinking about that as a mechanism of policy change is obviously incredibly powerful. We have to make sure that we recognize that that's going to affect how our academic medical centers or our community health centers that have medical training are going to be thinking about their curricular delivery. And the trickle-down effect to medical schools, such as the one we sit in right now, is a little bit different, right? Obviously, given medical schools research enterprise and medical schools educational mission and the like. That being said, I mean, I think clearly there's a great piece in the New England Journal from a couple months ago. Tom Naska, from the head of the ACGME, writes where he talks about going on clear visits, which are these new visits that the ACGME has put out to actually see what people are doing in terms of meeting the theoretical goals of residency. And having just left residency, I sort of acutely aware of this. They were stunned to see that in systems-based practice, nobody was doing anything in terms of learning QI, but could check off that they had filled a module that they were probably doing, as I did, clicking through in the middle of an ER shift just to make sure I got my HIPAA certification and being done with it, right? So not exactly the most efficient or effective way of thinking about how we build the population health skills, how we build the leadership skills, how we build the management skills, how we build the team-based learning skills to really think about creating change at any level, be it in subspecialty or in primary care, anywhere in American medicine. So this is going to have, we think, an effect if we think about previous IOM reports and sort of the impacts that we've had to error as human moving forward thereon. But the question is that, is it enough to only change how we think about graduate medical education for medical trainees and not think about how we change the paradigm for interprofessional education at the undergraduate stage, be it for physician assistants, nurse practitioners, medical students, and the like? There's a lot of work we have to do. This is the first time we're finally shedding light on it. It's not enough, but it's clear that this is the kind of call to action that we can use using an advocacy skill set to really move forward. Nothing? Wow.
I think another thing that medical students often look at is to look at what's valued when they're applying for the next step, whether that's residency, whether that's a research position, whatever that is. And oftentimes the question is, how many papers have you published? How many posters have you done? Well, what if someone said, how many quality improvement projects have you done? I think if medical students can see that the system really values their expertise or their knowledge of population management or quality improvement projects, like we really do in the UK, we put a tremendous amount of emphasis. I must have done 20 times the amount of quality improvement projects in the UK than I've done in the US. I think we would see medical students who are gunners, as you guys call them, or much more focused, their eyes are going to start focusing on these tasks, and other medical students are going to see them, and I think that will help look at the culture of, looking at quality and looking at populations when they see that these are prized commodities.
And I do think that there's actually there's an appetite right now for exactly what you're saying, that even Harvard is thinking about an innovation pathway as another way to encourage advancement and promotion. Thinking back 7 or 8 years ago, there were very few people who were getting up in the morning and saying, I want to come in and make changes in my practice. I want to make a little dink in the armor there. And now, when residents come and interview for primary care physicians, everybody's coming and saying, I'd love to see patients, I'd like to do that, and this is what I'd also like to do. This is where I'd like to make changes right now. This is how I want to make my impact on the way we're delivering healthcare. And that's new, and it's quite exciting and inspirational and challenging in terms of finding jobs. But if you're still looking, call me. But these are things that we're seeing right now in terms of change. I think we have about 5 minutes left, and I was just hoping we can just go down the line really quick. For those in this room who are considering careers in primary care of one sort or another, you 5 represent people who can offer some really interesting and important insights into that. If each of you had one thing that you could advise the people in this room to think about or prepare for or to consider as they're making decisions in their lives towards primary care, what would it be?
I guess I'm starting. Mentorship. I mean, you've heard some amazing things here tonight, and I've really kind of felt so energized by hearing them. And finding a mentor, finding someone that's doing really innovative things, and seeing if you can get involved in some way, seeing if you can listen to what they think is the next big thing. I think that would be something that I would be very interested in if I was looking at primary care.
So I think, one thing as medical students, you spend most of your life with medical students. But if there are ways in which you can really connect with your friends who are not medical students, who have gone down the nursing pathway or are a pharmacy or something like that, and really brainstorm with them, think bigger, think outside of the box. I think that's actually really valuable.
I get a couple, maybe.
Yeah, you can have
Thank
3.
you. I got 2. So,
You can take ours if you want.
okay. Listen. This work and pushing change forward in a sclerotic environment requires you to be courageous. I'm not saying that we're pinnacles of courage up here, but what's courageous is when Andreas sort of challenges us to say, yeah, that's pretty good, but I don't think it's good enough. Okay? That's courageous, and you're right. And I hope that you see whatever we're doing here and you say, that was okay. We in my cohort can do it better, and let me show you how. Awesome. Do it. Absolutely do it. Which goes to the second point. Don't listen to the grumps. There are a lot of grumps who just whine and moan, or even worse for the undergraduate or the early trainees in lots of health professions. They do the whisper campaign of the hidden curriculum. There are only 4 things you can go into: radiology, ortho, anesthesia, derm. That's where all the money and happiness is. That's the biggest load of BS. I, as a medical student, always wondered, how was it that like the world's expert on sort of physician workforce strategy was like a fellow...
Have you ever seen an unhappy dermatologist?
I have.
Okay, I was just asking. I was just curious.
Totally
Please go
have.
on. All right.
Do you want her phone number?
No.
Honestly. So, I mean, the grumpy strategy, I mean, everybody has an opinion when you go through training. They talk so much. They listen so little. If you have what's in your core, be courageous, go move forward with vim, with vigor, with challenge, with all the things that make you you, and forget about the grumps. And then finish it with being optimistic. Of course it's hard. It's by definition hard because if it were easy, it would have been done already. So it takes that courage, that one-minded track of not listening to the grumps and the ability to stay optimistic and have a lot of fun with it, because it's an incredible privilege every day, at least in my job, to wake up and do the things that I do.
3 much shorter points. So
I didn't
listen-
say you could have 3. I said he could have 3. No, okay, you have 3.
So listen, look, and read. And this sounds really trite, but you're going to see a lot of different things in like forums like this talking about really exciting ideas and exciting groups and exciting initiatives, and lots of us soft talking for a long time. But listen to sort of what makes you happiest. And like when as a third-year medical student, I noticed that on my internal medicine rotation, I was the least unhappy to wake up. And that was really impressive to me, like my idea of like, this is something that I should do with the rest of my life. So listen, develop that internal sort of, system and listen to it. Look for places that are going to support the kind of work you want to do and really give more than lip service, and that have, like I know for myself, the support from health coaches, the support from a team to really do the kind of the transformative work that I was hoping to help affect. And then read. You can read The Economist, you can read The New Yorker, you can read Metro, you can read the comic pages, whatever's going to help you think about something outside of medicine and connect to your patients in any sort of meaningful manner. Go read that. Although the New England Journal is an excellent resource as well.
How many do I get?
As many as you want.
Oh, that's so sweet. I give Mitch about a $20 bill. Primary care is an open playing field. We literally have a lost generation of leaders. We really do. And so I'm going to say to you what one of my mentors said to me when I said, what should I do? She basically said, step in and step up immediately. Do not wait. Doesn't matter if you're a medical student or a PharmD student or a resident who hasn't finished. Step in and step up. And the other thing I would say is that you got to build a team, because we're in totally uncharted territories. There's learning to do, there's support. It's not going to be easy. You need other people in the boat with you as we go through these choppy waters. And it's also a lot more fun that way, right? I mean, we laugh a lot at our practices, right? Yeah, laughter is good. I would say the last part is just be strategic. We've never been strategic in healthcare. We've just thought the data, right equals might, the truth equals power. But it doesn't. It actually doesn't. That's why there's a 17-year delay between us definitively showing something in healthcare and it actually being incorporated into general practice. Data is important, but it's necessary. It's not sufficient. So what other things can you bring to bear to get the person or institution or group to give you what you need to get the job done? We have to be more strategic. And we're actually having an awesome primary care reception in a week and a half. That's the other thing you have to do. You have to come to it and drink wine and listen to us talk about primary care more. It's on the 26th, Royal Sonesta. Check out our website. You're all invited. Thank you. primarycareprogress.org.
Well, guys, thank you so much for your time and your insights. It's really appreciated.
Thanks so much to our panelists. I think our judges have finally finished deliberating. The entrants were so good, they've just wrapped up. So we'll bring them in. I'd like to introduce Dennis Dimitri to give some final remarks. He's the Clinical Associate Professor and Vice Chair of the Department of Family Medicine and Community Health at UMass Memorial Medical Center and the Vice President and President-elect of the Massachusetts Medical Society. And we'll have the judges come in to give the final verdict afterwards.
Okay, that was my question. Thank you. So I guess my remarks go first and the awards come second. Is this on? Turn it on. Right there. Okay, now I'm on. So this is an incredibly difficult panel to follow. I mean, they hit a home run on every comment about every issue. I hope that you really take to heart what you heard from them tonight. I'm here as a sort of a last-minute person. I met Jennifer just a week or so ago at an event at the Massachusetts Medical Society and asked her, what's up with this program that you're putting on around primary care innovation? And the next thing I knew, she put me on the agenda to give these closing remarks. So she's a ball of fire, I must say. I tried to take a few little notes as things were going along here to try and see if there was some way to pull together a little bit of a sense of what we were talking about here today. And one of the themes that came back to me was about innovation and change. And individuals who kind of think about and write about and talk about innovation and change oftentimes talk about the difference between technical change and adaptive change. And technical change is the easy one. That's when you sort of know what the problem is and what the answer is, and you put it into place and you fix things. But what we heard more about here today, I think, is what's referred to as adaptive change. Adaptive change is much more difficult because it really requires that you kind of change the hearts and minds and souls of people and the systems in which people are working. And that's what we're talking about here with the transformation of primary care that has been going on for a while. I'm a family physician. I've been practicing for 30 years, and I've seen incremental change over a long period of time. And although, as some of the questions indicated from the audience here, we aren't where we want to be, let me tell you, we are a long way from where we used to be. And I think we should all take heart in that. And, you know, putting that adaptive change into place is what will get us to where we eventually need to be. We need to be persistent about our passion for primary care and innovative changes in primary care, because it is that will change the entire health system. That's what I firmly believe. Jennifer asked me to particularly comment on, you know, where do I think you should go from here? You know, if you're students or residents at the front end of your career, what do you take from here tonight and where do you go next? And I must say that, Andrew, you kind of stole my thunder on this one a little bit, because I really, what I hope is that those of you who are on the beginning of this trek will maintain your passion for primary care going forward, that you won't let yourselves get beat down by the system that is resistant to that adaptive change. Because whenever there's change, for some people, for some parts of the system, for some elements of the organization, that means loss, and people are resistant to loss, and we need to keep pushing and overcome that. The other word that Andrew used that I had on my cards here is advocacy. And I hope that all of you will come to appreciate the importance of your personal advocacy in a lot of different venues. Advocate at your medical schools. That is incredibly important. I remember being here at the town hall 3 years ago when the students at this school objected to some of the changes that had come from the school administration around primary care. And man, oh man, the changes that have occurred since then, to me as an outsider, I'm not a Harvard person, as an outsider to observe that change has been really amazing. The other place you need to learn to advocate is with your legislators. I know that for many of us, we feel like politics is kind of dirty these days, but the fact of the matter is that if you don't dig down and get involved and talk to your legislators from, you know, the local level, Beacon Hill, right down to Capitol Hill in Washington, it will be hard for you to affect any change. And again, I particularly want to mention this to students and residents who are in the room, because when an old guy like me shows up at my congressman's office, he goes, "Oh, it's you again." But when I show up with some medical students with me, I just sit in the back of the room and I let the medical students go. And students and residents and young physicians carry a tremendous amount of weight with our legislators. So please show up there, get involved, and advocate. I've seen it work, and I'll close with one just little anecdote of my own personal experience about this that convinced me. In 2006, those of you who've been in Massachusetts for a few years know that the state legislature here passed a universal health insurance law. So it turned out that that was not nearly enough. Everybody had insurance, but there was not a systematic way for people to really access the care they needed in the system. So in 2008, I happened to be the president of the Mass Academy of Family Physicians and had the opportunity to lead a group of physicians, family physicians, to Beacon Hill. And we sat down and we talked with the lead healthcare folks in legislation and informed them about what they needed to do to make the healthcare insurance reform that they had passed really functional. And we talked to them about things like primary care, which they didn't fully understand until we explained it to them. And we shared things like the Barbara Starfield data, and if you don't know that data, you should go read it. It talks about why systems built on primary care are so much more highly functional and effective. And we talked to them about innovations like patient-centered medical home and what that meant and how that could transform the way we delivered care to our patients. And we talked to them about things like healthcare workforce reform. And lo and behold, the legislation came out 2 months later, and every single one of those things was in the legislation. And I firmly believe it was because we went down there and talked to them about it, because when we talked to the aides of the legislators about this, they didn't know what any of those terms meant. We are a tremendous repository of information. We are the content experts on healthcare and healthcare reform, and we need to go and talk to our legislators about that. And the last plug I'll make is that there is a role for you in organized medicine around this. I obviously am involved in organized medicine, but I haven't always been. And let me tell you, if you don't want organized medicine, be it the Mass Medical Society or specialty societies or whatever else, to be like your mother or father's AMA or your grandfather or grandmother's AMA, then you got to get involved to make it be what you want it to be. And I think those organizations are different today than they were in the past. And I think that that's because of the input and influence of a new generation of students, residents, and physicians. So I'll put in a plug for you to get involved in organized medicine as a way to be effective going forward as well. This has been a tremendous evening. I have really enjoyed sitting here and listening to everybody, listening to the innovation projects, and I want to now, I guess, go ahead and do the awards for those projects.
Yes, thank you, Dr. Dimitri. Oh, it's like Miss America.
Yeah, just call me Burt Parks. Anybody remember Burt Parks? Am I the only one in here who knows who Burt Parks is? Okay,
Sorry for the
Jennifer,
delay.
I'm gonna...
Judges, come on in. Come on in. Thank you for the deliberation process. Andy will give a brief spiel of how difficult it was.
Yeah, every time I'm at any kind of challenge, and I've been at a couple of different sorts, the judges always come back and say, boy, it was like a really difficult, hard deliberation, and we wish we could have given awards to every single one of those. And if you ever want to understand that, you just have to sit on a judging committee for a challenge, because it was true. We were almost like, I don't know, we were almost operating like a jury in a real tough court case. There were several rounds of voting of different styles, and it was hard, but we came to a decision.
So at the Oscars a few years ago, they learned not to say the winner is, but rather the award goes to. So the fifth runner-up award goes to AJ. Oh.
Crowd favorite?
Crowd favorite.
Crowd
Oh,
favorite.
oh, excuse me.
Oh, okay, different bouquet.
Blame Jennifer for that. She gave me the wrong flowers.
Oh my. Crowd favorite.
Okay, we're going to start with the crowd favorite, and that award goes to AJ Coley. All right. Now, in no particular order, a runner-up award goes to Cole Zanetti. Congratulations. our next runner-up award goes to Howard Haft. Another runner-up award goes to Rebecca Glassman. Our final runner-up award winner is John Moore. Okay, drum roll please. And the top award, the #1 award, the winner is Gina Luciano.